And we have the great opportunity of introducing our next speaker. We have Dr. Chifu Jeffrey Yang. He is a thoracic surgeon at Massachusetts General Hospital.
Great. Thank you so much for the opportunity to speak with you today. It's been such a great conference. I want to thank Lynn and Dusty for the opportunity to be here and just learn from all of these great presentations and all the wonderful conversations. So thank you. Today, I'm going to talk about surgery in small cell lung cancer. And these are my disclosures. So small cell is actually very personal to me. This is a picture of my grandparents, and I was very close to my grandfather, and he was diagnosed with small cell when I was in college, and I was part of his care team and spent a lot of time taking care of him. And because of that experience, it really drove me to want to be a doctor and to take care of lung cancer patients. So I'm really, really appreciative of this summit and just everything that the work that LiveLung has been doing for small cell lung cancer patients. Today, we're going to have a brief overview in terms of the background and also in terms of some of the landmark studies and then advances in chemotherapy briefly, as you have heard, and then some studies that I have done in this field, and also studies that I'm going to hopefully launch in the next few months. So historically, surgery has not been indicated for the treatment of small cell. And that's because of studies from these two groups in 1973 by the Medical Research Council, that was in Britain, and then 1994 Lung Cancer Study Group. If you notice those dates, it's been a while since we've had a randomized trial. And how long has it been? Well, the first of the trials was done by Dr. John Scatting. And as you can see from this picture, it's been a while. In 1946, he was a founding member of the Medical Research Council in England, editor of Thoracic from 1946 to 1959. And then this was the big trial that was published in The Lancet, 1966. So this is only one of two randomized trials ever about surgery in small cell. And basically, at that time, they just took everything that was diagnosed by bronchial biopsy. And the way they did bronchoscopies was through this. This was a rigid bronchoscope and the technology was from 1897, where Gustav Killian performed the first bronchoscopy to remove a pork bone. But yeah, that's how they diagnosed small cell back then. And then they assigned 144 patients to either thoracotomy, just a big traditional incision and removal of the lung cancer, or radiation. And the results were they had a complete resection in 48% of patients. And but a lot of the folks did not end up receiving surgery because, as you know, it's small cell back then was very aggressive. And the radiation arm, 85% of folks were given radiation, and about 15% did not end up getting curative intent radiation. And these were the survival curves. So pretty much a overlap. In fact, the radiation arm did a little better than the surgery arm. And if you look at the x-axis, that's in months. So in 24 months, unfortunately in that study, almost nobody made it to 2 years. And this is a table that quantifies that. And I highlighted the box in red, which is at patients who made it out to 5 years. And you see that there was 1 in the surgery arm, and then 3 in the overall group. In 1994, so that was about 2.5 decades later passed before you had another randomized trial. And this was from the lung cancer study group. This was done in the US. And the patients were diagnosed in 1983 to 1989. and they had to have what was thought to be resectable small cell lung cancer. But this is before the age of PET scan and CT scan. And so some of these folks probably already had spread. In fact, most of them probably already had disease in the lymph nodes. And the treatment regimens they got chemotherapy first, and then surgery, and then radiation afterwards. And then in the no surgery arm, they got chemotherapy first, and then radiation afterwards. And also about 146 patients with 70 to surgery and 76 to no surgery. And the resection rate here was better. So in the other study, it was about 48% actually were able to go through surgery. And this study was 83%. But the median survival was not good, and it was still lower than the no surgery group. So 15.4 months versus 18.6 months. And then there were no differences in 2-year survival. Only 20% made it out to 2 years. And these are the survival curves. And as you can see, they really just dive straight down. So because of those two trials, historically, the prognosis was thought to be so poor for folks who got surgery that it was not thought that surgery was applicable or relevant for the conversation. And that's it. Those are the only 2 randomized trials in small cell lung cancer. So one of my hopes eventually is to do a randomized trial again for small cell and surgery, but we're not quite there yet as a field. This is a quote from one of our renowned thoracic surgeons in the field, Thomas Shields, and he said, "Surgical intervention for this disease fell into disrepute." Since those studies, there have been many advances in chemotherapy, which I'll just briefly touch upon because I know it's been discussed a lot here already. In the 1970s, you had more combination chemo regimens. And then in the 1980s, there was the introduction of platinum-based chemotherapy, or etoposide. And then this concept of combining it with radiation. And then also further development of whether or not you can use radiation and chemotherapy at the same time, and prophylactic cranial irradiation. So that has, in the 3 decades since that lung cancer study group trial design, you've had all these new developments in chemotherapy, and then even further developments in 2002 with the Norwegian study group in Japan, clinical oncology study group, where there was the development of the modern regimens that we see today, where you have cisplatin etoposide plus concurrent radiation. During this entire time, because of these better developments in chemotherapy, there have been different surgery centers and different hospitals who have tried surgery for earlier stage disease and have found good results. And I'll skip over those because they basically all showed that surgery had much better outcomes than previously thought. And what I did in my research when I was a resident was look at long-term survival after surgery for different stages of lung cancer. And so, by the way, I was a resident at Duke, and so it's great to be back home, so to speak, and great to be back in North Carolina. And but this is a survival curve of a paper that I looked at where we evaluated folks who got surgery and then folks who got concurrent chemoradiation for earliest stage lung cancer, earliest stage small cell lung cancer. So this is N0 lung cancer that had not spread to the lymph nodes. And the blue line is the surgery line, and the red line is the concurrent chemoradiation line. And this was much better than anything we had previously ever saw. Essentially 50% of folks were still able to be with us 5 years after their diagnosis and surgery. So that was much better than those other survival curves. This was another analysis where we did trying to adjust for different confounding variables, because anytime you look at these retrospective studies, you're always worried that there's some unmeasured confounding. And we matched by different variables, including comorbidity scores and the different stage and tumor sizes. And then we did a multivariable analysis as well. The hazard ratio of 0.58 just means that surgery was associated with much better survival. We also looked at for more advanced disease, so not N2 disease, but N1 disease, and looked at the survival curves. And the blue line is the surgery line, and the red line is the chemoradiation line. The surgery group also did better in the N1 population as well. And this was the case even after propensity score matching and adjusting for all these unmeasured variables. And in the multivariable analysis, hazard ratio of 0.74, suggesting that surgery was associated with better survival in these carefully selected patients. So in this day and age, what kind of operations do we do for small cell? I'll go over some of these different types. So you have a wedge resection, which is just taking a slice of lung that's at the very far left. And then you have a segmental resection where you take a part of the lung, and also a lobectomy where you take out the entire lobe. I would say if you know that you have small cell, most surgeons will go straight to a lobectomy. And a wedge and a segment are less common, but depending on how a patient's lung function is, you would still consider doing some of those smaller, lesser resections. As a bit of a background, so these are pictures of what a lobe looks like on the left, and then also what segments look like on the right. So segments, several segments comprise a lobe, and these pictures highlight that. So a wedge resection is where you take a little bit of lung, and just a slice essentially, and then you have a rim of lung tissue that's normal around it. And the positives about this is that it is the quickest lung cancer operation, and people do well and recover well from this. So this is what it looks like as a diagram, where you would lift up the lung and then just simply go across it with a staple. The picture in the middle is a cartoon picture, and then the picture on the right is what it actually would look like through the camera. A segment, this is more complicated, but it's still taking less than a full lobe. And the positives about this is that it preserves the lung tissue. It's an anatomic lung resection, and you could get a good lymph node dissection, but it does lead to more recovery time. So sometimes you get more air leak, and the length of the operation is a little bit longer. So these are some pictures of what a segment could look like. What I mean by an anatomic lung resection is you're really trying to dissect out the small blood vessels and the small airways that are going into that part of the lung, whereas with the wedge, you really just staple across the lung. And after the fine dissection and the detailed dissection, a figure on the right shows basically a removal of that segment. And then a lobe is where you take out the entire lobe of the lung. And this is the most classic operation. This has been around for at least 50, 60 years. And what we think is the best operation for small cell right now, but it does lead to the biggest impact because it's the most lung removed. We generally try not to take out the whole lung. That's called a pneumonectomy. And that often is really hard to recover from. So a couple example pictures of what a lobe would look like. So the picture in the middle, you have the different lobes splayed out, and then you can see some of the blood vessels going through there. And then the picture on the right, the top right corner, the instrument is dissecting across the airway. And then the lower left corner is after you start dividing some of the structures of the airway. And then in here, you have, in the picture in the middle is basically a couple more steps of the operation where you start to divide across the lung tissue to start freeing up the lobe. And then you have access and a viewpoint of some of the blood vessels. So the picture on the right is a picture taken from in the operating room where the camera is showing the instrument where it's dissecting across some of the blood vessels that are going into the lobe. In addition to the actual surgery where you take care of the lung, there's lymph node dissection as well, where you try to evaluate different parts of the lymph node. Because sometimes these lung cancers do spread to different parts of the lymph node. And it's an important part of the cancer operation because the PET scan might not be accurate. PET scan can be wrong about 10 to 15% of the time. So it is important to actually take out these lymph nodes and see to help with staging and further treatment. And these are what some of the lymph nodes look like in the operating room. Picture on the left, those little black figures, those are the lymph nodes. A lot of these lymph nodes are black just because of the pollution that we breathe or from smoking. And then picture on the right is after you fully clean out those lymph nodes. The good news about surgery these days is there's a lot of minimally invasive operations where just through some small incisions and put in a camera and long, thin instruments, you can remove the lung instead of a big thoracotomy and a full posterior lateral thoracotomy, a big incision from front to back. And so picture in the middle is showing these different VATS instruments, these long, thin instruments. And then you may have also heard about robotic-assisted thoracoscopic surgery, where using the robot, this is the Da Vinci robot on the left, and then in the middle, it's a little bit hard to see, but the surgeon is actually sitting down, and through this console, it's almost like a video game. People say that if you play a lot of video games, you'll be probably good at robotic surgery, and using that console to manipulate the arms and then perform the robotic surgery. And but basically the main point of minimally invasive lung cancer surgery is so that you don't have to do the big thoracotomy, which is what you see in the middle there, where it says open thoracotomy. So you try not to break any ribs, you try not to spread any ribs, and then the benefits are less postoperative pain, faster recovery. And so nowadays, folks can usually go home in about 1 to 3 days and then have a 2 to 4 week recovery at home. And then you could review the final pathology report. I had an example right here about stage 1A for non-small cell, and then proceed to surveillance for 5 years. And we do see more and more small cell these days, which I will get into later. So the next topic is what happens after surgery for small cell. And right now, the NCCN guidelines recommends adjuvant chemotherapy with surgery for these earliest stage lung cancers, and also recommends prophylactic cranial irradiation for patients who have undergone complete resection with adjuvant chemo. I know that's not always the case. It really is dependent on a discussion with your medical oncologist, but basically, those are the general recommendations. And this is something I also looked into when I was here at Duke, which was does adjuvant therapy lead to better outcomes? And so the red line is showing folks who did get adjuvant chemotherapy, and you can see that it's better than the blue line. And then specifically, we also mapped out the different lines and looked at what happens when you have chemotherapy with prophylactic cranial irradiation. And that's the green line up at the top. So folks who got chemotherapy with prophylactic cranial irradiation did do the best. And so because of this study, that's still the current guideline right now in the NCCN. So in summary of that, patients with pathologic stage T1 to T2 N0, M0 small cell can benefit from both adjuvant chemo and chemotherapy with prophylactic cranial irradiation following surgery. This is a figure that we've looked at over the years, just the number of small cell lung cancer resections or the number of small cell lung cancer operations that have occurred, and you see that it's going up. The y-axis is 1,200. So by 2024 now, probably every year there's over 1,000 small cell lung cancer operations. And some of this is really tied into earlier detection of lung cancer, either through screening or through CT scans that have detected these nodules. For example, if somebody had a pneumonia and needed to get a CT scan. These are studies that I know were talked about today, but this is all the immunotherapy studies for later stage disease, so not for surgical patients. And so I'm excited to show you, I titled here, a proposed phase 2 trial, but this is hopefully gonna launch in about 6 to 10 weeks. This is a trial that I'm leading with Jacob Sands, who you heard speak yesterday, where this is the study design where folks who get surgery for T1 to T2 N0 or N1 small cell lung cancer. In this study, they would be enrolled and get adjuvant chemotherapy with immunotherapy. And so we're really excited about that, this next step. So because of all these great findings from these other trials for small cell in the later stage sphere. So the regimen would be chemotherapy and immunotherapy every 3 weeks for 4 cycles, followed by immunotherapy. And then I listed some of the details about the immunotherapy. It would be durvalumab at 1.5 grams. And then chemotherapy would be cisplatin or carboplatin and etoposide. So in conclusion, it's really exciting time for surgery in small cell lung cancer. New randomized trials are needed still, and I do hope that we're going to be able to do a newer randomized trial for small cell in the future, but not quite. We're going to have to first do the adjuvant chemo IO study first, and that I do believe that surgery for N1 disease can be safely performed, but you do want to talk about it in the multidisciplinary fashion, and because not all N1 disease is the same. And then the question mark of what happens for N2 disease. I think that is still a big question mark, and probably at this point in time, not many folks are getting surgery or getting recommended surgery for N2 disease. And then chemotherapy and prophylactic cranial radiation should be considered following surgery for limited stage small cell, and then adjuvant chemo IO. This trial that I just shared with you, I'm excited that it's going to be launched in the next hopefully 6 to 10 weeks. It took 3.5 years to develop that. So I'm actually really excited about that. And then the last thing I wanted to share with you all is Lynn asked me to talk a little bit about this. Some of you know that I've been working on lung cancer screening through the American Lung Cancer Screening Initiative. This is a nonprofit, which I started when I was a resident in North Carolina at Duke. And we're trying to raise awareness about lung cancer and lung cancer screening. And I don't know if the audio will work. Fundamentally, I really do believe that if you tell people about lung cancer screening, they will get screened. But this was just a couple months ago in the Today Show. Well, let's see if... is there... let's see. Is there a mouse where I can... let's see. Okay, well, that's okay. I think in the interest of time, I'm just going to show that basically the Today Show had this entire segment on cancer screenings, and unfortunately, they left out lung cancer. Yeah, cervical, breast, colorectal, and prostate. So that's really what we're trying to do, is we're trying to get students all across the U.S. to teach people and teach community members about the importance of lung cancer screening. So right now we have almost 50 chapters from the South to the East Coast, Northeast to Midwest and the South. And we've had over 450 events ranging from health fairs to white ribbon builds to canvassing and other tabling events. These are some examples of what we've done in Boston, for example, going to farmers markets, going to health fairs, going to community centers and teaching folks about lung cancer. And in Chicago, one of our students gave a presentation, for example, to the dining staff at UChicago to 500 employees. And in that one session, got 60 patients signed up for lung cancer screening. Thank you. And in California, working with mayors and governors, we actually do that for everybody, including we had a proclamation, mayor's proclamation in Durham, and a governor's proclamation signed by Governor Cooper about the importance of lung cancer screening and lung cancer awareness. But this is some of the examples of our California outreach where they talked with city councils and met with the mayor and also built white ribbons. Some of the really nice feedback that we've gotten in the community are community members telling us these are the only people who will ever come to tell us about this stuff. And then in Houston, I had no idea about lung cancer screening, and I've smoked since I was a teen. And then in Chicago, please come back. Everyone needs this message too. Some of you also may know about the White Ribbon Relay, so I wanted to give everybody an update about this. This is basically where we have 5 ribbons in circulation right now, and we're taking it through different cities and different college chapters, and also just to different lung cancer survivors and just out there in the community. I don't think this video is going to work if the other one didn't, but basically we launched this one first. This ribbon we launched in Boston and Cambridge, and then really has gone to all these different places. Oh, actually, that works. Does the audio work? This is in New York City now. It's the same ribbon. It's been flying to different places or getting driven to different places. This is a little bit old of a video, so I will show you. Right now, it's actually to 38 chapters, and every pin you see there is where it's made its way to. So I really appreciate, because I know some of you here have already signed some of these ribbons, and these are just some pictures. We got Varad, who is our ALSI UNC college chapter president. They're receiving ribbon, and then different lung cancer survivor groups, and also you see Heidi there on the upper left-hand corner, and just throughout the entire country. So we are trying to see if we can get this more out there in the media. So some of our team members had written a little blurb about the White Ribbon Relay, and so we'll see how far that goes. And then Natalie Wing is leading this, not just the statistics project, where really trying to feature stories of lung cancer survivors. And so if anybody is interested in sharing some stories, please go on their website or just contact me. We'd love to feature your story either through this project or through our podcast, which we've had a lot of lung cancer survivors speak, and we're really appreciative and grateful for their support. In terms of what I've been doing personally on the lung cancer screening side, I launched this Inspire study with Alex Potter and Deepti and others, where we're screening Black women who are at high risk of developing lung cancer. And so far, I'm happy to share with you, we're almost at 100 folks who have gotten screened. And thank you. And it's been a great learning experience for me, because as a thoracic surgeon, I don't actually do that much screening personally. But through this, I've screened every one of these folks and just learned a lot about the different challenges that people have had to overcome, and then different considerations. So it's been great to be part of this. Can we have audio here too?
You get a lung screening, especially if you have like maybe a family history of lung cancer, or maybe if you're a smoker, something to that effect. My dad died from lung cancer 4 years ago. And unfortunately, he didn't make it, but hopefully, with the study, more people will live.
So that was Crystal. By the way, everything here is just explicitly with Crystal's permission through signed consent and things like that. But we're really excited about the welcoming reception that we've had about this study. A lot of the community members have just told their friends and just brought them on, and we've gotten them screened. So excited about that. And then the last thing I wanted to mention in terms of an update is this new initiative where we're trying to get signs about lung cancer screening in different places across stores. And so one of the first places we did this is in Fitchburg, Massachusetts, which is about an hour out from Boston. And there's a lot of folks there who are eligible but haven't really gotten screened. And so we worked with this health inspector, Sean Tannerwatt, who was just fantastic. And he put up these lung cancer screening flyers everywhere. So this is in the Board of Health, where there's now a flyer about lung cancer screening. Sean is in the middle. I'm standing on the far left, and I'm here in the picture with Maggie and Jimmy Craner from our team out there in February. And but this is a list of all the stores and shops that there are lung cancer screening flyers out there that Sean put up, which is fantastic. And so one of the things we did was just visit some of these stores, because it almost sounded too good to be true that you'd have these lung cancer screening messages. So we went to Fitchburg Variety, for example, and that's me and my wife next to the ATM that has a lung cancer screening flyer. You can't really see it, but in blue right there. And then, but we noticed in Massachusetts, there's a lot of signs about lung cancer in general, either about stopping smoking or, the quit line and things like that. And so there's already this culture of having this information there, but just not about lung cancer screening. So this is Maggie at, the front desk of this store, and you can see they just put it right there. So if you're gonna go get a Coke or a Snickers bar, you're gonna see information about lung cancer screening. So we're really excited about that. And then we started this in another town in Newton, Massachusetts. This is Julia and Kiana, where I don't know if you can tell, but that blue flyer right there, that's lung cancer screening. Yes, it's right there. Yeah. Yeah. I'm sorry? How can we get some of those? I'd love to take them. Yeah, I'd be happy to give you these flyers. And this is in Newton again. This is another a sign about lung cancer screening right there at the cash register. And this is another shop as well where we really they just put it front and center. And so far, we just launched this, but we've gotten about 40 people who have scanned the QR code and asked us about lung cancer screening information. So we're really excited about that. Yeah. So that concludes my presentation, but I put down my contact information here and then also my cell phone. You can always feel free to text me or call me anytime, and then feel free to email me. And then also love to invite you all to some of our events on Zoom. We have annual end of the year update, and as well as distinguished lecturers that come in and we just really welcome anybody to join any of these events. It's just, and especially we love to have lung cancer survivors there because it's really inspiring to our students. And so thank you all for being here, and thank you again for the invitation to come talk with you. Thank you. Thanks.
And thank you so much. I have a question, a twofold question. This is really great. I was wondering, if considering surgery in limited stage, is there a limitation about how large the tumor is? Because my tumor was very large. So after I saw those pictures, I was like, it looks like you could only take a small portion. And the second part of the question is, what is your projected accrual rate for the trial that will possibly come out very soon?
Thank you. Yeah, so in terms of the second question I'll answer first is, right now we're aiming for about 65 patients, and then hopefully it'll be concluded fairly shortly in the timeline of clinical trials, maybe about 3 years, and then at which point we'd like to launch into a big phase 3 trial, a randomized trial for that. And with regards to your first question, I think that it really depends on where the tumor is. So if it's right in the middle of the lobe, even if it's very big, usually those operations can be done through a minimally invasive approach. And if it's more central, then that's where you have to think about what kinds of, is it actually resectable? And then, or do you have to take more than the lobe? So, but it does depend on where the tumor location is and also the size.
Yeah, because I didn't know what N1 and N2 were.
Question, also, Dr. Ying, could you just, I had adjuvant chemotherapy. Mm-hmm. Could you just explain what adjuvant chemotherapy is and also what neoadjuvant chemotherapy is? Oh,
thanks for that question. Yes, so adjuvant chemotherapy is when you give chemotherapy after surgery. And so that word adjuvant, that's what it means. And then neoadjuvant is when you give the chemotherapy before surgery. And typically for small cell at least right now, the approach has been do surgery first and then give adjuvant chemotherapy afterwards. But in non-small cell, there's been a lot of momentum and movement in giving the chemotherapy and immunotherapy first before surgery for patients who have stage 1B to 3A disease. And I wouldn't be surprised if small cell eventually moves into that approach as well.
Vicki has a question, and then I think you're going to introduce our next guest. Is that right, Dr. Yang?
Yeah.
Thank you, doctor, for your service. Question. I've noticed all the posters that you place throughout the United States, wherever. Are the services free for lung screening?
Yes. So in terms of lung cancer screening, Medicare covers it fully. So anybody over 65, Medicare will definitely cover it. Anybody with private insurance, it should be almost universally covered now for private insurance. And between 50 and 64 years, that's the part where it's a little hard. If people have Medicaid, for example, it depends on what state you're in. So in Massachusetts, everybody can get lung cancer screening for free. Doesn't matter what age you are. But in some places, Medicaid doesn't cover lung cancer screening. And that's something I didn't put in the presentation, but that's something that our team at ALCI that we're working on right now. We're trying to support, there's this bill called the Increase the Lung Cancer Screening Act, which is a bipartisan bill sponsored both by Democrats and Republicans, where we're trying to make the Medicaid much more inclusive so that nobody has to worry about the costs of lung cancer screening. Yeah, exactly. Yeah.